Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the pharmacology of the beta blockers. Beta blockers are the drugs which blocks the beta receptors. So, the beta blockers blocks the beta receptors. Okay. They are adrenergic antagonists. They are adrenergic antagonist. Okay. So from the adrenal medulla we have two hormones is released. One is epinephrine, another is norepinephrine. They are also called adrenaline, noradrenaline. So in case of sympathetic stimulation, we have secretion of epinephrine and norepinephrine. They are coming from the adrenal medulla. There is a part of the adrenal gland. This adrenal gland, this is the kidney. Here is the kidney. This is the adrenal cortex, adrenal medulla. From adrenal medulla, we have the epinephrine, norepinephrine. These two hormones are released due to sympathetic stimulation, and they work on the alpha 1 receptor and alpha 2 receptor, also beta 1 receptor and beta 2 receptors. Today I will discuss on the beta 2 receptors. Okay, so these are the sympatholytic drugs. We have found the beta blockers. Now we'll go through the types of beta blockers. Types of beta blockers, or we can say the classification of beta blocker. We have the selective beta blocker, selective, like that of the atenolol, acebutolol. Okay, atenolol, acebutolol. Okay, then metoprolol, ismolol. Okay, so we have the selective beta blockers: atenolol, ismolol, acebutolol, metoprolol. Okay, we have also non-selective beta blockers. Non-selective beta blocker. These are the propranolol, okay, sotalol, okay, then propranolol, sotalol, and also timolol, and many other drugs like pindolol. Okay, we got that. Selective. Why they are called selective? Because they work mostly on the beta 1 receptors more than that of the beta 2 receptors. Non-selective work on both beta 1 and beta 2. Okay. So selective beta blocker mostly work on the beta 1 receptor, and if dose is high, then it also work on beta 2. But non-selective beta blocker work on both beta 1 and beta 2. So what is the beta 1 and beta 2 receptors? Location of the beta 1, beta 2 receptors. So beta 1 receptors are present. Beta 1 are present in the heart. Okay, heart, we have the SA node, AV node, we have the right atrium. Okay, and this is the, and also the heart wall, we have muscle, the myocyte. Okay, so beta 1 is located on the myocytes or muscles of the heart, or myocardium, myocardial cells, myocytes of the heart, myocytes of the heart, as well as it is also located in the SA node, AV node, and other part like AV bundle. Okay, SA node, these are the conducting system of the heart. AV node, AV bundle will get the beta 1 here, beta 1. Okay, beta 1 is present in the heart. This is the heart. Okay, this is the conducting system of the heart. SA node, AV node, may have AV bundle here. Okay, then we get the left branch, right branch, Purkinje fiber. Okay, so beta 1 is located in the heart. So selective beta blocker are also called cardioselective. Okay, beta 1 receptor is also present in the kidney system. Kidney in the juxtaglomerular cell, juxtaglomerular cells. Okay, juxtaglomerular cells are present in the tunica media of the afferent arteriole of the kidney. Okay, so the juxtaglomerular cell releases the renin, and renin is associated with that of the renin angio system, angiotensin aldosterone system. Okay, that is essential for the maintenance of blood pressure. Okay, so in the kidney we have the juxtaglomerular cell that releases renin, that is associated with renin angiotensin aldosterone system. Okay, so we got the beta 1. Here also we get the beta 1. What is my beta 2? Beta 2 is present in many places. Beta 2 is present in the lungs. This is bronchi. Okay, right lung. This is the left lung. We got that. We have the beta 2 in the bronchi and bronchiole. If the bronchi, bronchiole, we have smooth muscle there. Bronchi, bronchiole, we have smooth muscle, we get the beta 2. It is also present in the blood vessel. Okay, blood vessel. So lungs, blood vessel. Also we get beta 2 in the pancreas, especially the pancreatic islet cell, especially the alpha cell which releases glucagon. So pancreas that also contain the beta 2. So beta 2, especially the islets of Langerhans, the alpha cells of the islets of Langerhans, beta 2. Also it will get in the muscles, skeletal muscles. It is present in the wall of the urinary bladder, present in the uterus. Okay, many places we have the beta blocker. I mean the beta receptors. So beta 2 receptors. Beta 1 receptor is confined mostly in the heart and the juxtaglomerular cell of the kidney. Beta 2 is present in the lung, in the blood vessel, in the pancreatic islets of Langerhans alpha cell, muscles, urinary bladder, also in the uterus. Okay, we got the non-selective beta blockers. Okay, we got sotalol, sotalol, timolol, pindolol. Okay, we have another type of beta blocker. Those are not perfectly beta blocker. They have also some alpha 1 blocking activity. These are the levitalol and carvedilol. Levitalol and carvedilol. They have alpha 1 blocking capacity plus beta blocking. So these are the special type of beta blocker with some alpha 1 blocking capacity. Okay, we got the classification, selective, non-selective, and some special type called, it is called third generation beta blocker with some alpha 1 activity. Okay, we have some of the beta blocker has also some type of agonist activity like that of the acebutolol. It has some agonist activity. It is antagonist but it also partly agonist. This is the acebutolol. Okay, we have also in pindolol, that is also partially agonist. Okay, so we got the classification of the beta blockers. Okay, we got that. Now we go to the therapeutic indications of the beta blocker. Therapeutic indication. Therapeutic indications of beta blocker. What are these? Number 1, this is an antihypertensive drug. So, in the management of hypertension, in angina pectoris. Angina pectoris because we'll go to the mode of action. We'll find out that angina pectoris in case of myocardial infarction, especially in acute stage infarction. Okay. Then hyperthyroidism. Then arrhythmia, especially supraventricular arrhythmia. Okay, supraventricular arrhythmia and prevention of migraine. Prevention of migraine headache. Okay, and to remove some anxiety, especially stage anxiety, or people like to give an interview or stage program. Some people like to get some propranolol and they have less nervousness, anxiety. Okay, so we got the therapeutic use of the, also another important point, that is glaucoma. Glaucoma is managed by beta blocker, especially non-selective beta blocker like that of sotalol. We have some drop for that. Also propranolol has also some effect. They decrease the secretion from the ciliary body of the eye. So in case of glaucoma, we got the therapeutic indication. So it is an antihypertensive drug, anti-angina drug. It is used in acute myocardial infarction In hyperthyroidism, it decreases the heart rate. It maintains the supraventricular tachycardia. Okay, so it is important. Prevention of migraine headache, in the management of anxiety, and in the management of glaucoma, especially open angle glaucoma for the chronic use. The therapeutic indication of beta blocker. Now, mode of action. Okay, mode of action. In the heart, its mode of action, negative inotropic, and chronotropic action. Okay, so it will decrease the force of contraction of the heart. It will decrease the rate of contraction of the heart. So in case of when it decreases the oxygen demand of the myocardium, decreases the oxygen demand of the myocardium. Myocardium is the muscle in the wall of the heart. Okay, we got its action on the heart. It is the other action on the eye we just discussed. Decreases the aqueous humor formation from the ciliary body. Okay, so you got in the eye, it has some action. Okay, this is management for glaucoma. Okay, we got that. Also in the pancreas, it decreases secretion of glucagon. Okay. So there is in the pancreas, the islets of Langerhans, we have the alpha cell. Okay, that releases glucagon, that is decreased by the beta blocker. Okay. In the blood vessel, this multiple action like on the lipid metabolism. Okay, so it is essential for lipid metabolism in the blood vessel. Okay, so we got in the muscle is some role, also in the uterus, and also in the urinary bladder. The beta blocker, the beta receptor has some role. They are the receptor for the epinephrine, norepinephrine. Okay, we got the mode of action. So it will decrease the heart rate, decrease the force of contraction of the heart, decrease the release of glucagon. So it decrease the blood glucose level. Okay, so these are the actions of the beta blocker. Okay, we got that. Now we go to the adverse effects. Or side effects, whatever you say. Adverse effect, certainly it has negative inotropic and chronotropic action on the heart, therefore it will cause bradycardia. It will cause hypotension. It will cause peripheral vasoconstriction. Okay. It will cause hypoglycemia. Okay. It will cause dyslipidemia. Okay. So lipid metabolism will be altered. So we got that. And most important is the bronchospasm. We know that the sympathomimetic drug causes bronchodilation, like that of albuterol, or even the epinephrine injection will cause dilatation of the of the bronchus. So if we block the beta 2 blocker in the lung, there will be bronchospasm, bronchoconstriction that may aggravate the asthma and chronic obstructive pulmonary disease. So the beta blocker is contraindicated in case of asthmatic patients, especially the non-selective beta blocker. Even the selective beta blocker is also relatively contraindicated because in high concentration, the selective beta blocker may not be selective. It may work on both beta 1, beta 2 receptor, may lead to bronchospasm. Okay, so bronchospasm is a very important adverse effect of the beta blocker. Then we have to add the sexual dysfunction. Sexual dysfunction due to many reasons, maybe due to lack of blood flow, especially in the male genitalia. Also, there will be loss of libido because of lack of blood supply to the brain. Okay, that may happen. And there is lassitude and asthenia, so there will be lack of libido. So we got the bradycardia, hypotension, peripheral vasoconstriction. So what will happen? Peripheral part of the body will be cold, feeling cold. Okay, so and also another important point, masking the symptoms of hypoglycemia. So masking, if we know that our brain is dependent on glucose for its energy, so our brain cannot tolerate hypoglycemia, will get tachycardia, sweating, even may have convulsion, coma, and death. So this tachycardia, sweating is masked by the beta receptor drugs, especially non-selective beta blockers. Okay, so person with diabetes mellitus may have hypoglycemia due to insulin, but may not have sweating and tachycardia because of the sympatholytic action of the beta blockers. That is very important to us. So adverse effect, we got the adverse effects of beta blocker. Okay, and certainly there will be, we know that in mode of action, the beta blocker actually causes hypoglycemia. It decreases the release of the glucagon. Okay, we got that. So we got the adverse effect. Now we must know something about drug interactions. Drug interactions. Our drug, the beta blocker, it is metabolized in the liver. It is excreted through the urine by the means of the kidney. So some drug also work on the liver. So some drug, what will do, that will potentiate the antihypertensive activity or increase the antihypertensive activity because they prevent the breakdown of the beta blocker. So increase antihypertensive activity, antihypertensive activity. We can say action by what? By cimetidine, then antipeptic ulcer drug, cimetidine. Okay, cimetidine. Also, we have other drug like that of the furosemide, chlorpromazine. Furosemide is a diuretic. Okay, and chlorpromazine, antipsychotic drug. Chlorpromazine. Okay, they will prevent the breakdown or metabolism of the beta blocker. So there will be potentiation of the or increase in the action of the antihypertensive action of this drug. Okay, so decrease antihypertensive action, antihypertensive action by some drug which will break down the the beta blocker in the liver, it will increase the breakdown like that of the barbiturates. Okay, like that of the phenytoin, that is an anti-epileptic drug, phenytoin, also by rifampin, anti-TB drug. Okay, so drug interaction is very important to us because people will take the beta blocker for the rest of their life once they are established as a hypertensive patient in most cases. So it is important to know the drug interaction. So we got the drug interactions. Okay, now we have to know that some of the drugs are also agonists, like that of the acebutolol and the pindolol. So this drug may be useful in patient who has bradycardia and who has diabetes. Okay, because the sympathetic system symptom may not be totally blocked by this drug because they have some agonist activity. They are antagonist, also they are agonist partly. These are the acebutolol and the pindolol. Okay, then we have some special type of drug. One is the levitalol. Okay, levitalol. Another one is the carvedilol. Okay, so levitalol, they are alpha 1 and also beta blocker. Alpha 1 beta blocker. This is a medication, very important medication, can be given intravenously. Very good medication to control blood pressure very quickly. Okay, so for the quick action, IV dose is present. Quick action, very quick action. Okay, and it can be used in the management of the hypertension associated with pregnancy, even in the management of the eclampsia, pre-eclampsia. Okay, so it is useful in emergency, we can say hypertensive emergency. Also it is in case of in pregnancy related hypertension, pregnancy related hypertension. Okay, hypertension, you can say it, hypertension. Okay, we got that. So this is a useful drug, levitalol. It decreases the blood pressure very quickly. Okay, carvedilol is also a good medication, also work against the alpha 1 and beta receptor. So this is useful in case of heart failure because they decrease the peroxidation of the fatty acid plus decrease the thickening of the blood vessel. So they are useful in hypertension with heart failure. Hypertension with heart failure. Beta blocker should not be withdrawn suddenly. So you must remember that beta blocker should be withdrawn if it is indicated, withdrawn gradually if indicated. Okay, so it should be tapered. Okay, tapered by 1 week time. Okay, dose is tapered by 1 week time. Otherwise, we have upregulation of the beta receptors, and if we withdraw the medication suddenly for any reason, then that may lead to arrhythmia, that may lead to heart myocardial infarction, even may lead to stroke. So never withdraw the medication suddenly. it should be on a gradual tapering fashion. Okay, that is very important to us. Beta blocker application. It may lead to arrhythmia. It is a management for supraventricular arrhythmia, but it may cause also arrhythmia. And some medication of the beta blocker group are very much notorious to cause cardiac effect, like that of sotalol. Sotalol, that may lead to ventricular fibrillation, ventricular tachycardia, arrhythmic ventricular tachycardia. Okay, so sotalol, even it may lead to a clinical condition is called torsade de pointis. Okay, that may be caused by, so we must do the EKG. ECG is important to us. Okay, we'll see the PR interval. We look for the QRS wideness, QRS. Okay, and also look for the torsade de pointis if we use specifically this drug. Okay, also even the propranolol is lipophilic, may go to the central nervous system in excess dose, may lead to convulsion, coma, and death. Okay, so we got that. Now we'll go to understand how to manage beta blocker toxicity. So management